Hi, everyone. Welcome back. I hope everyone had a lovely lunch break and had an opportunity to just take a break. And now we have a few more fantastic sessions for you. I'm just going to wait about 30 seconds for folks to join, and then we'll get started. Just waiting for a few more folks to join. Okay, I think we'll go ahead and get started. So as I said, welcome back, everyone. I hope you've enjoyed the talk so far. I wanted to let you know that you unfortunately won't have the option to submit questions for our next talk. It's a relatively short talk, so there won't be the option, the Q&A option that you've had in the previous talks. So our next speaker is going to discuss the evolution of surgical interventions in Parkinson's disease. Dr. Amir Faraji is a neurosurgeon in Houston, here in Houston. We're happy to have him. He's at the Houston Methodist Hospital. He received his medical and doctorate degrees from the University of Pittsburgh and his undergraduate degree from the University of Florida. He completed residency and fellowship in stereotactic and functional neurosurgery and epilepsy surgery at the University of Pittsburgh Medical Center. He also completed a second fellowship in peripheral nerve surgery at Washington University in St. Louis. Dr. Faraji specializes in epilepsy surgery, peripheral nerve surgery, and stereotactic and functional neurosurgery. He's very experienced in neuromodulation or deep brain stimulation, brain tumor surgery, peripheral nerve disorders, radiosurgery, and epilepsy surgery. We're so grateful that you're speaking for us today. We know you have lots of great information, so we'll let you go ahead and get started. Welcome, Dr. Faraji, and thank you again.
Thank you so much, Erin. It's my pleasure to be here, and thanks to HAPS for having me. It's my pleasure to talk to you today about how the surgical treatment of Parkinson's disease has developed over the past almost century to the current state of the art. And then I'm going to also touch on new areas that we are developing, not only at Houston Methodist, but in the neurosurgery community as a whole. And then as we move this field forward for Parkinson's patients. So in particular, the first thing I wanted to show is just the general timeline of how some of these surgical treatments have developed. So almost 100 years ago, 90 or 85 years ago or so, in Montreal, a neurosurgeon named Wilder Penfield started mapping the function of the brain, the cortex and the outer components of the brain in terms of their function, and developed a map that correlated function to the anatomic structure of the brain. But then we discovered that the circuitry for many of the movement disorders are located deep inside of the brain and on internal structures. And to get to those areas safely, neurosurgeons then developed in the 1940s to 1950s high definition, minimally invasive techniques of stereotactic to hit those targets deep in the brain. The first pacemaker was released in 1960. That was the first neural or I guess computer or electrical interface to the human body. That was released in 1960, and it was adapted over the ensuing few years to come up with a neurostimulator for pain control, et cetera. Levodopa, which is the mainstay treatment for Parkinson's disease in terms of dopamine replacement, that was released in 1967. And there was this lull of about, almost 10 years or so where doctors were understandably using levodopa to treat Parkinson's disease, but then the surgical mainstay treatments sort of fell off in terms of innovation. But as we recognize that long-term levodopa use has adverse effects, there was increased interest in surgical treatment again, to the point where in 1987, a landmark trial done in France was basically developed deep brain stimulation to treat essential tremor and Parkinson's disease, and then the targets were further refined for Parkinson's disease over the next 5 years or so. The first commercial system came out in 1997, and FDA approval was about that time as well. And Parkinson's DBS was approved in 2002. And I'll get to that in a second. But I want to show you where this all started. So again, almost 100 years ago, this is Wilder Penfield in the upper left corner. He's one of the neurosurgeons that I mentioned. And without going into gory detail, on the right is the cortical structure of the brain. And he would map out with electrodes each function as the patient was awake. actually. And he could see that, oh, this was involved in arm movement, face movement, leg movement, et cetera. And these numbers correlate what parts of the brain were responsible for each of these movements. To get to deep areas of the brain, there was a surgeon in 1939, about the same time, named Dr. Myers, and he, by chance, was operating on the deep structures of the brain because a patient came in injured, actually, from a propeller injury. And he was able to access those deep structures of the brain and then also map them, which would be useful, again, in the initial stages of understanding the circuitry for Parkinson's disease. Just to give you an idea of how these structures are located. So the outer structure of the brain where Penfield in 1936 were operating, that was the cortex off to the side here. But these are the deeper structures that are involved in the circuitry of Parkinson's disease and the targets that we select that are inside of the brain. And that's why we use these stereotactic or minimally invasive methods to hit those targets for DBS, because in particular, we don't want to transgress or hurt a lot of brain structure getting to them. So this is one of the first apparatuses for the stereotaxy. And so what you can see on the left is it's pretty cumbersome. I'm going to fix this to the skull with pin sights, but there's a lot of components that move and a lot of potential source of error for this. Also, as you can imagine, there were no MRI scans or even CAT scans back in 1947. And so these physicians, Spiegel and Weiss, used X-rays and actually injected contrast agent into the ventricles or the fluid spaces of the brain to understand the relationship of internal structures to those areas. And so they were using pretty crude imaging, but at the same time could actually hit many of these targets with good accuracy. Leksell is a Swedish physician, and he developed a second apparatus, which is actually still used today for many applications. And it's a little less cumbersome, as you can see, but the initial treatment for this was ultimately to be used for actually radiosurgery or treatment with radiation. And some of the first work with the Leksell frame system was used for radiation treatment in Sweden in the Uppsala labs. This is an example of some of the first work where he treated with, actually in this case, a focused radio frequency electrode. And so what you can see is you can burn a certain area of the brain, which is this arrow involved in Parkinson's disease. And this is Leksell's initial mapping that he used for that. This is the first cardiac pacemaker that came out, really 1957, but then 1960, as I mentioned, which was when the commercial device was available. And this originally was an external unit that was powered externally and had wires that went into the patient, but that was obviously very cumbersome. And so over time, these internally implantable pacemakers were developed. And then medicine understood that we could do a very similar thing for pain or neuromodulation or even deep brain stimulation in the 1980s. In 1960, scientists and medical doctors really tried understanding how Parkinson's developed. And one landmark study showed that the dopamine producing areas of the brain were markedly reduced in Parkinson's, which is this P, versus the control group or the normal patient in C. And so even with your own eyes, you can see that the dopamine producing areas of the brain are markedly less in the Parkinson's patient. And so that's the thought then for dopamine replacement therapy that ensued over the, starting in 1967. At the same time, doctors were performing lesions of the brain in different areas, trying to understand the components of circuitry. This is one example of a campotomy, which is a lesion in a certain area of the brain involved potentially in Parkinson's disease. But what these authors found was that there was a reduction in tremor amplitude in patients with Parkinson's disease as you were stimulating that area. And so you can see in the bottom component, you have a tremor of the patient, and then when you stimulate, it turns off, and then you turn the stimulator back off, and you get the tremor back. So you can create reversible effects to the tremor with stimulation. So dopamine came out, as I mentioned, and the point of dopamine is to replace and timed dosing via an oral medication that crosses into the brain and replace the dopamine lost through Parkinson's disease. And the goal is to keep the medicine dosed within a range where you're not having bradykinesias or tremor, for instance, in the off period, but also not having side effects from the medicine and being dyskinetic or having rhythm movements. And later in the disease process, it becomes harder to dose these medicines. It's much easier earlier on in the disease state with the onset of initial motor symptoms. But this was first published in 1969, as I mentioned. In the 1980s and 90s, again, we used radiation treatment. Instead of putting a needle down, we could actually focus radiation, such as with gamma knife or the stereotactic radiosurgery systems, and we could create lesions without an invasive function. So this is paralleling to today, where we even can use ultrasound techniques to develop the same lesions without cutting the skin. We were doing that for 30 years with radiation treatment in some respects. And ultimately, in 1987, Benabid in France, as I mentioned, developed the first DBS system for tremor associated with Parkinson's disease. And this is an example of tremor and drawing spirals, such as with a just general essential tremor patient. But as you can see, the goal is to reduce a tremor that can be debilitating or result in decreased quality of life and improve the patient's quality of life with deep brain stimulation. It involves an electrode or two that go into the brain with wires down the neck to a battery pack that's in the chest, typically in the chest. And then, as I mentioned, over the ensuing 5 years or so, we looked at multiple targets, the globus pallidus, the subthalamic nucleus, et cetera, really understanding their function and how they're involved in Parkinson's disease in particular. And these two targets, as I mentioned, are the mainstay of treatment for Parkinson's patients now even. So DBS was approved initially for essential tremor in 1997, and then for Parkinson's disease actually in 2002. So we have almost a 20-year history of FDA approval for this, and DBS has been done now for almost 30, 35 years in current clinical practice. In 2009, there was a study that came out in the Journal of the American Medical Association, including many physicians from even the Houston area, and it includes the conclusion of this study basically was that DBS was generally superior to levodopa for Parkinson's symptoms, and when you had on-off fluctuation, and when patients were suffering from troubling dyskinesias or motor symptoms. So typically, DBS is a good option that should be discussed with patients at least one time in the course of their treatment for Parkinson's disease, if not progressing to surgery itself. And multiple studies have come out, again, over the ensuing decade or more, which shows that patients have benefit in terms of on time, their therapeutically controlled time of almost 5 hours a day, more than best medical therapy alone, with decrease in medication doses, reduced tremor up to 75% perhaps, and also improved quality of life. Again, in multiple high-profile landmark and well-vetted studies. Typically, just again, because we're talking about the state of art of technology, I want everybody to know what symptoms are typically helped by DBS and which symptoms may not be helped by DBS. So again, DBS can help increase on time, as I mentioned, and reduce bradykinesias and rigidity. It can reduce medication dose in some patients. It can improve dyskinesias, especially related to medicine and dosing. And it can effectively treat tremor, but it does not necessarily affect non-motor symptoms of Parkinson's disease, or if patients have gait or balance problems, cognitive problems or thinking problems, or depression, in fact. And unless that depression is centered around Parkinson's symptoms as being debilitating, that depression may not get better with DBS. And so a traditional candidate has an initial response to levodopa treatment, has some on-off fluctuation, has some dyskinesias perhaps, resting tremor, does not have a dementia or a severe depression, and then ultimately have a normal MRI and be able to undergo some anesthesia for the procedure itself. And so this sums up basically what I talked about in terms of the historical development of deep brain stimulation in particular, which parallels what we talked about for Parkinson's disease surgery in general. And over the past 2 decades, I'd like to focus towards the right part of this timeline here, where we can see we've developed new electrodes to the brain, perhaps even closed loop systems for epilepsy, which can be then adapted to Parkinson's treatment. But we've developed new batteries in terms of rechargeable batteries. We've developed, more importantly, directional DBS electrodes where we can steer the current one way or the other to mitigate and reduce side effects. And I'm happy to show you an example of that in a second as well. So these are the 3 main manufacturers for DBS devices: Medtronic, Abbott, and Boston Scientific. All 3 now have directional leads. And the goal of these companies is all uniform in developing really high definition programming options for directional capability of steering current, but also improve rechargeable batteries, and also moving towards responsive sensing and therapeutic closed loop devices as well. This is an example of directional technology with the DBS lead. So instead of a single circular or cylindrical contact, we can segment those into 3 or 2 or more contacts. And so as a result, you can steer the electrical current. So instead of emanating a sphere, you can create an irregular shape, but that can direct the current away potentially from an area that involved in side effects of DBS programming. So this ultimately should result ideally in better outcomes. This is an example of omnidirectional or the circular stimulation versus directional lead. So the single electrode can go in and emanate a circle, where the directional lead can go in and direct the electric current off to one side, and then really reduce side effect of being off target in some respects. So this is one aspect of this. The other aspect is getting the lead accurately in the target in total, so that you can combine both accurate targeting plus accurate programming with directional leads to result in better outcomes. At Houston Methodist, we perform DBS surgery in 2 stages generally. Stage 1 is awake or asleep, depending on the patient and their disease state and their preference ultimately. So awake surgery involves robotic assisted DBS with the ROSA system, and a sleep surgery can be done either with the ROSA system with robot or intraoperatively in the MRI scanner with the patient completely asleep using a guidance frame and real-time imaging in the MRI scanner. About 2 weeks later, in general, patients come back for their stage 2 procedure, which is their battery pack procedure. And that's generally done under general anesthesia with the patient asleep completely. I just want to show some illustrated images of what the OR experience may look like for you. And so the center panel is what the Leksell frame looks like. It's the frame that we attach to the head. It allows us to make a 3-dimensional map of the brain and also to register to the ROSA robot system to make a 3-dimensional map to allow us to do the surgery. And that's placed on the patient's head with sedation so that they don't remember the experience, but also it's not a painful procedure either. This is the ROSA robot, which is the arm that lines up to the trajectory, and then I operate along the trajectory of the robot to put the DBS leads in. Again, the robot is used to increase the precision of stereotactic procedures. It simplifies these procedures by standardizing them, and also allows us to pre-plan, import-export imaging, and verify the accuracy post-surgically as well. There have been multiple studies looking at the accuracy of the robot versus traditional frame or surface registration techniques. And ultimately, the ROSA robot and robotic methods have been found to be more accurate, or at least on the same order of magnitude, if not better accuracy than the traditional methods. And so many centers, including here in Houston and including at Houston Methodist, have adopted the use of the ROSA robot as an example for DBS surgery because of the accuracy benefit. And this is one of the first studies that I was part of looking at the robot to assist with DBS surgery. And we basically described our initial learning curve. Initially, we had a certain error that was improved markedly with increased experience using the robot to the sub-millimeter level. And it's important as a result to go to a center that's experienced in using robotics if you plan on having DBS surgery done with robots, because that's when the kinks have been worked out and outcomes are optimized. This is how we register the robot with the Leksell pin site itself. And so this is the reason that we place the frame on patients, is to really make this 3-dimensional map to allow us to perform surgery. And then we hook the patient into the robot, their head supported and rested on this holder that goes into the robotic arm. And the patient is generally asleep for this part when we start the surgery, and then wake up during the middle of surgery for the awake testing. And on the top right panel, you can see just awake testing of the patient and their tremor during the DBS procedure itself. Awake testing is the gold standard to assess the response to neurostimulation, but also we can evaluate and minimize off-target side effects during the process. We can perform intraoperative recordings, including now with really high definition, excellent microelectrode recordings that allow us to determine the neurophysiology along each tract of the deep brain stimulation process, so we can find the best place to put the electrode physiologically as well as just anatomically. And then afterwards, of course, now we have advanced imaging, so we could look and visualize the electrodes after surgery and evaluate where they are and how we can program accordingly to result in the best outcomes. This is an example of patients for Parkinson's disease that I did with optimal placement of the leads in the subthalamic nucleus. But beyond the robot, device placement, we can also again place DBS electrodes asleep in an MRI scanner with real-time image guidance. And so with the patient asleep, we have the head supported in a special MRI compatible frame. And we place a tower on the head that allows us to dial in coordinates. And when we dial in these coordinates, we can adjust the trajectory of the lead and place it to the target with high accuracy. And it turns out that whether you're asleep or have an awake procedure, generally the efficacy is the same with DBS in a recent study. And these show some images of the clear point or the MRI guided placement, where we put a small grid on the head temporarily that allows us to make basically a entry point determination, and then we can place the guidance towers and dial in the DBS electrode to their targets. The advantages, again, of traditional awake DBS is that it's the gold standard. We get functional verification of electrode placement with intraoperative testing, but it does require cooperation of an awake patient. So for some patients, that may not be possible. As with the sleep case, we get really good anatomic verification of electrode placement with either the MRI or an O-arm or intraoperative CT scan, but it really relies on anatomic targeting alone without any functional verification. But it turns out, again, the outcomes are similar of both of these surgeries, and the right choice will be whatever is right for that patient in terms of the discussion with the neurosurgeon, the neurologist, and the patient themselves. And patient preference is heavily considered to deciding which one of these paths to choose. A new modality in movement disorder treatment is using focused ultrasound. And really the indication for this is for essential tremor. It's not for Parkinson's disease, but perhaps Parkinson's disease is on the future for this, where we can, again, similar to the work done in the 1980s and 1990s and even before, creating lesions and burning lesions in the brain. What we can do is create temporary reversible lesions with the ultrasound, evaluate an effect before making the final burn, if you will, with this technique. So this is done as an outpatient procedure, typically with no incisions, the same as a gamma knife procedure. It does involve a full head shave. You have to have a CT scan to calculate the density of the skull beforehand as well. And again, this is typically done for essential tremor. And so this is an example of basically the drawing spirals, and you can see the tremor improve in this patient. You can do only one side at a time. You cannot treat both sides as of now with ultrasound or lesioning technologies. But you can create lesions in the brain. And ultimately, there's a lot of work geared towards understanding outcomes of this procedure, as well as expanding indications, perhaps even to Parkinson's disease. This is all being done as part of clinical trials and experimental research right now. But I would estimate that in the future, and even in the next 5 to 10 years, lesioning technologies will come back towards the Parkinson's disease realm, similar to what was done again in the 1980s. And finally, the last new avenue that I would elucidate or explain for Parkinson's disease is the focused delivery of gene therapy. So instead of placing just a DBS electrode down a path to a typical target, what we can do is use small hollow catheters using the same stereotactic or a high definition MRI guided techniques and deliver a viral capsule that has a genetic promoter inside. And that gene therapy promoter can actually transgenically produce increased production of dopamine, for instance, as an example for a target, as long as we get good coverage of the target. And so this is being done in the experimental world to try to improve outcomes of Parkinson's disease without the advent of neuromodulation. So this is also a possible option for Parkinson's patients as well. So I would say, in summary, the surgical treatment of Parkinson's disease blossomed really in the 1950s and 60s with the advent of advanced stereotactic, minimally invasive methods to access deep areas of the brain, understand the circuitry of the brain as well. And we've been producing lesions for a long time, which were eventually followed by neuromodulation strategies, which DBS is the gold standard today. And even technologies such as ultrasound are going to have a high bar to cross when it comes to having improvement in quality and outcome versus DBS, because DBS is so good for the motor symptoms of Parkinson's disease typically. But in any event, DBS has been heavily evaluated and does improve symptoms and quality of life in patients. And We are developing new device programming technologies that also strengthen the abilities to improve outcomes. A multidisciplinary team is involved in caring for Parkinson's patients so that we can identify which surgical target may be addressed. We can identify the appropriate device or device manufacturer, and also program the device post-operatively together as well. And then at least at my institution, Houston Methodist, we use advanced surgical robotics, MRI, other techniques to really safely and accurately place DBS electrodes during surgery with patients either awake or asleep completely, depending on their preference. And while risks exist with any type of surgery, we really try to minimize these risks and increase accuracy and improve patient outcomes. So with that, I know that there's no formal question and answer session, but I'd like to at least give our direct number, 713-441-3784, but also my email address, and make it myself available to anyone if there's questions in the future about DBS or about even other modalities of treatment for Parkinson's disease. I'm happy to always discuss, and I appreciate the opportunity to join you guys today.
Thank you so much, Dr. Faraji, for all this great information. We sincerely appreciate your time today. That was just a fantastic talk. I can't believe you got through so much in such a short period of time. So
it was a whirlwind, so
I
hope I kept everybody on board with me, but I appreciate the opportunity. It was fun.
Yes, absolutely. We loved having you. So I would just like to invite everyone to please join the next session, which is long-term management strategies with levodopa, and you'll hear from Dr. Arjun Terakad. So we look forward to seeing you there. Thanks again.
Thanks, everyone.
Bye.